Oh,
At
good.
least, at least the country is keeping us very safe. So
Good.
tell us when to go on. We're going live.
We're live now, Doctor.
We're live? Okay. So good morning, good evening, and good night to everyone across the globe that's joining us for this edition of the EIOC Journal Club. My name is Shaheenah Dawood, and I'm a consultant medical oncologist coming to you all the way from the United Arab Emirates. And today we'll be talking about integration of immune therapeutic regimens within the realm of resectable gastric cancer and gastroesophageal junctional tumors. And I'm pleased to be accompanied by an awesome panel of people that are KOLs from the GCC region as well as from the United States. And I'm going to allow them to introduce themselves. So, Yelena, maybe you can introduce yourself.
Hello, everyone. Thank you for that kind opportunity to share our experience. My name is Yelena Janjigian. I'm a medical oncologist, physician scientist at Memorial Sloan Kettering Cancer Center in New York. And it's been a pleasure to focus on this topic of gastric and esophageal cancer for over 15 years. So there's been some major breakthroughs in the last 5 or 6 years, particularly now focusing on resectable early stage disease. And only today we finally got EMA approval of durvalumab in combination with FLOT. So it's a great opportunity to, I think, discuss the data and get your practical input on it.
Thank you. Ahmad, would you like to introduce yourself?
Good evening, everyone. Ahmad Ghoche, medical oncologist, Sultan Qaboos Cancer Center in Oman.
Dr. Dia? You're muted, Dr. Dia. Yes, go ahead.
Yeah, good evening. Diaeddine Trad, medical oncologist at Barjeel Royal Hospital, Al Ain.
Maitha.
Hello, good evening, everyone. My name is Maitha Al Riyami. I'm from Dubai. I'm an oncology dietitian working in City Hospital.
Maroun.
Hi,
My
I'm
partner
Maroun.
in crime.
I'm Maroun El Khouri. I'm an oncologist at American Hospital in Dubai.
And Dr. Usman.
Thank you. Hello, everyone. Usman Ahmad. I'm a thoracic surgeon at Cleveland Clinic, Ohio, and Abu Dhabi. Pleasure to be here.
And as you can see, we have a very diverse group of people here, all who come together to manage patients with gastric or gastroesophageal cancer tumors. So I'm going to very quickly share my slides. I was given a last minute request to do a very brief introduction because obviously we all want to hear Yelena and what she has to share with us. I'll very, very quickly talk about the landscape of resectable gastric and gastroesophageal junctional tumors in the last decade. These are my disclosures, and if anyone would like to get online with me to network, I would highly encourage you to scan the QR code. So we know that gastric cancer is the fifth most frequently diagnosed cancer and the fifth leading cause of cancer-related deaths worldwide. What's interesting about stage 3 gastric cancers and gastroesophageal junctional tumors, as you can see in terms of the 5-year overall survival, is actually less than what we typically tend to see for stage 3 colorectal cancers and stage 3 breast cancers, where we know we have made some significant strides. The typical management of these patients either includes a cross-type regimen where we start off with chemoradiation therapy, followed by surgery, followed by adjuvant therapy, and then surveillance, or a perioperative chemotherapeutic approach where we use chemotherapeutic agents such as FLOT, followed by surgery, followed by chemo, and then surveillance. And then, of course, doing surgery up front, which I hope we don't do that much of nowadays, then going on to chemotherapy and surveillance. Some of the questions that we ask ourselves in the realm of these patients is, first of all, in 2026, what is the role of radiation therapy in those patients with early stage tumors? As you know, the cross used to be the standard of care. A couple of years ago at ASCO, we saw at the plenary session the results of the ESOPEC trial, which actually randomized patients in the early stage setting to either FLOT or cross-type regimen. And you can see that the prognostic outcome of patients who actually had perioperative chemotherapy with FLOT was superior to doing a cross-type regimen. We've seen the results of the Top Gear. This was a randomized phase 3 trial of perioperative chemotherapy with or without preoperative chemoradiation therapy for resectable gastric cancer, and practically no benefit to adding that radiation therapy piece. And I always, tell patients who come to me who shop around and then, go to other people and say that radiation therapy should be incorporated. And I try and tell them the data does not actually support this. So we know that the role of radiation therapy is rapidly decreasing. Probably it's for a select few who cannot tolerate chemotherapy. It also tells us that we need to be discussing each case individually in the MDT. So then what is the ideal perioperative chemotherapy regimen? Now, we've certainly come a long way from looking at protocols like MAGIC, where we had an ECF type protocol, all the way to obviously what is now considered the standard of care, looking at a FLOT type protocol. We know that there has been a number of studies that's actually looked at intensifying chemotherapy with FLOT and other types of chemotherapy regimens. And we know that with a FLOT type regimen, not only has it worked very, very well, we also know that we probably hit a ceiling effect, because this is probably the maximum amount of chemotherapy that we can give our patients, which has actually made the lives of our surgeons much easier in terms of allowing for better resectability. We know that FLOT compared to an ECF type protocol is superior, with an improvement both in the median disease-free survival as well as overall survival. So we know that perioperative FLOT is probably the standard of care. Question is, can we do better? We know that adding chemotherapy probably isn't something that we're going to do, because it's already quite a toxic regimen, and something that we will be talking about in the discussion session. And then the question comes, can we actually modify by using immunotherapy? And then we know that the combination of chemotherapy and immunotherapy does have a synergistic effect, which is where Yelena is going to come in and tell us how immunotherapy in the perioperative setting may actually benefit. But before we go into that, we have seen actually the use of immunotherapy in the adjuvant setting. We did see the results of the Checkmate 577 study, which was one of the first studies to actually look at immunotherapy in this group of patients. These were patients with stage 2 or 3 gastroesophageal or esophageal cancers. It could be either adenocarcinoma or squamous cell, who had received neoadjuvant chemoradiation therapy, had residual disease post-operatively, and then were randomized to get either adjuvant nivolumab or placebo. About 30% of these patients had a squamous cell carcinoma, and DFS was the primary endpoint. You can see that at 5 years of follow-up, there was an improvement of 11 months median in terms of a DFS, and about a 16-month improvement in overall survival that was clinically meaningful. This year, or last year at ASCO, we did see some very interesting results from the Checkmate 577 trial, substratifying based on the PD-L1 score. And what we essentially saw was that it seemed that adjuvant nivolumab, the benefit seemed to be restricted to those patients with a CPS of more than 1, and patients with a CPS PD-L1 score of less than 1 actually did worse if you gave them adjuvant nivolumab. However, this was not a pre-specified endpoint, it was an exploratory analysis. We've seen results from the Attraction 5 trial, which was a phase 3 study of nivolumab plus chemotherapy as post-operative adjuvant treatment for stage 3 gastric or gastroesophageal junctional tumors. And again, the primary endpoint was relapse-free survival. And you can see practically no difference. We saw the results of the EORTC 1707 trial. Again, this was the adjuvant immunotherapy in patients with resected gastric cancer following preoperative chemotherapy and high risk of recurrence. That means those patients with node positive or an R1 resection. And interestingly, patients did worse in the experimental arm where they got adjuvant immunotherapy. So what is the role of adjuvant immunotherapy in the early stage setting? I think it has a very specific role in the Checkmate 577 realm, so we shouldn't deviate from that if we're going to use it. It does, the exploratory analysis of the Checkmate 577 study did bring in the question of whether we should be using adjuvant immunotherapy in those patients with a PD-L1 negative disease. Adjuvant IO with or without chemotherapy does not seem to add benefit. It does not seem to have a role outside the realms of Checkmate 577. Now, this takes us to Yelena's talk. What is the role of perioperative immunotherapy? So, Yelena, I am going to allow you to take it away and tell us what you think and give us your expert insights into now integrating immunotherapy into the perioperative realm.
All right, so let me just share my screen again. Okay. You did mostly cover a lot of the data. So I think, in the interest of time and so forth, we can even spend a lot of the, my 15 minutes for discussion of cases, if you'd like. So I could go very quickly. So, I thought it would be good for us to start with a case. Can you guys see my slides?
Yes, we can. We can.
Okay. So this is a typical patient, of course, that we're seeing in the clinic. And I think it's important to make a distinction between tumor location that is commonly seen in the Western populations versus in, people in the East, right? Because historically, endemic gastric cancer, distal gastric cancer is actually a surgical disease. And I don't know if we have any surgeons on the call, but it would be great to, have them also kind of speak up and tell us what their views are on, seeing someone in the clinic and then not operating on them right away, but sending them to us. But for us, it's so important as for medical oncologists because GE junction tumors are very different than distal gastric. And, when someone goes through an Ivor-Lewis esophagectomy or a total gastrectomy, their tolerance of therapy is very different than someone who has a distal subtotal gastrectomy, right? And so I think that's what initially drove the, the motivation to move more therapies perioperatively. So this is a patient who actually, was treated on the Matterhorn study, 2 centimeter mass above 2 centimeters above GE junction, extending into the gastric cardia. So this patient in our center would normally get an Ivor-Lewis esophagectomy. We test routinely for biomarkers, including MMR, HER2. It's very important for peri-op setting to know MMR status, and PD-L1. This patient had low PD-L1 expression. Claudin was not evaluated at the time because now it's more commonly used in metastatic setting. We also get a PET scan to assess a disease metastasis to supraclavicular retroperitoneal lymph nodes. And this tumor is intensely avid, so it's a useful biomarker for us. SUV of 10.3, moderately avid gastrohepatic lymph nodes, and laparoscopy was performed, was negative for metastatic disease. And so a patient like this, you do not need an endoscopic ultrasound because obviously, it's a very much advanced stage disease. So doing surgery first would not cure this patient. So as was nicely summarized, we have already 3 level 1 data, right? That chemoradiation adds nothing. And looking at from historical left to the right, cross data obviously is mostly in squamous cell cancer. So today we're talking about adenocarcinoma. And then next time I'll come, we'll talk about squamous. But for adenocarcinoma, radiation adds nothing, right? No improvement in survival. And no matter how strong your radiation therapy colleagues are in your group, you have to really explain to the patient, to the surgeons, but also to them that radiation adds 0 to survival. In fact, radiation doesn't even add much to local disease control. If you look at, and today we won't have much time, but if you look at the ESOPEC study, the local disease recurrence was the same with radiation or without, because FLOT is a very active regimen. So of course, ESOPEC and Top Gear were nicely summarized, basically showing that radiation does not add above and beyond a triplet regimen such as FLOT, which is the modern regimen. And when someone's quoting cross regimen to you, you have to see, and explain to them that this is adenocarcinoma. Now, of course, there's always going to be that patient who is too frail, too sick, too old, medically inoperable. And radiation in those patients may be a form of local control that, so if someone is not able to get surgery, radiation could be considered, but again, not as a form of, additional local therapy on top of surgery. Why is Checkmate 577 important? Well, I think it's important because it gives us context for biologic rationale for giving neoadjuvant therapy while the tumor is in place, right? So what happens, in melanoma, breast cancer, kidney cancer, lung cancer? I mean, there's been so much data already, both preclinically, but also clinically, showing that if the cancer is still in place, and if you're able to educate the anti-tumor immune response while the cancer is still in place, the benefit and the expansion of the T-cell, anti-tumor T-cell response is much more deeper and much more durable. And that's what we're really understanding, right? With disease-free survival benefit with Nivo, that's great. But why was there not a definitive and all-comers OS benefit, right? And you could say, well, because of the crossover and the age of immune checkpoint blockade in metastatic setting, et cetera. But I think biologically, it speaks to the fact that the immune response, the depth and the durability of it is affected because you really are treating, using micrometastatic disease, right, in the 577 to educate the immune response. But it's really not ideal. You need to really use the primary tumor while the lymph nodes are in place before surgery to educate the response. And this is what sort of conceptually is shown in this figure. On the top here, you have proposed rationale for adjuvant immunotherapy, right? And these are, the T-cell populations that are less diverse and there's fewer. While the neoadjuvant, obviously, while the antibodies, therapy is going through while the primary tumor is in place, the activation of many different diverse T-cell populations that then can continue to suppress the micrometastasis or expand while the patient is still recovering from the operation. And that's, for the first time, was demonstrated by the Matterhorn study, where we gave patients, as you know, close to 1,000 patients were treated in one-to-one fashion to receive durvalumab with FLOT or FLOT alone. I think the common questions that I get that maybe while I have you, I can just answer is, why 2 cycles? Well, it's not 2 cycles of FLOT. It's each cycle has 2 doses of FLOT. So the cycles are defined by Durva dosing, and Durva is once a month. So it's 2 doses of Durva, so 2 cycles with 4 cycles of FLOT adjuvantly and neoadjuvantly. So it's standard FLOT 4, if you think about it. The other question that I get quite often is, what about subgroup analysis for patients with node-negative disease or diffuse gastric cancer? Well, again, this was a large global phase 3. We didn't mandate laparoscopies, and we did not mandate EUSs. So, and the diffuse histology was not centrally assessed. So if they happen to note that it was diffuse histology, we captured it in the source document and analyzed it, but a majority of the sites do not assess whether or not, WHO classification. And so the largest cohort was actually not classified, which obviously diffuse histology was in that as well. And therefore I wouldn't, hang your hat on the diffuse histology subgroup. But with all those caveats, this was obviously an ASCO plenary, big deal, a New England Journal of Medicine paper, and now FDA approval. And what's important about this data is that in the time of immune checkpoint blockade use in metastatic setting, Despite that, there was clear overall survival benefit for patients who received immune checkpoint blockade as early as possible. In other words, when the cancer was still in place in neoadjuvant setting. So the primary endpoint was event-free survival, which clearly met, which 67% at 2 years versus 59%. And what's important to note is that in patients who had major pathologic complete response, which is less than 10% of viable cells left residual, or pathologic complete response, the survival benefit was even more dramatic, hazard ratio of 0.3. In other words, if you, as early as 2 months on treatment, right, if you see a patient like that, you can really reassure them and you say, listen, it's your chances of cure are nearly 100%, which is such a powerful statement to them. But also the other question that commonly asks, well, why do I need to get anything else? Well, I think the data is still out there to, even in patients with complete response or patients with no response, continuing therapy, if feasible, as long as they have an R0 resection rate and they're cured, is very important. And I decide whether or not to continue the treatment, not by pathologic tumor assessment, but what the patient looks like and how they feel, what percent of their body mass they lost, if they're able to tolerate FLOT or not. And most patients do require dose reduction. Nodal downstaging is also an important biomarker, and we showed dramatic improvement in nodal downstaging, which eventually translated to survival. As you see here, the downstaging was significant compared to pre and post-treatment. What about treatment, delivery, and surgery? Again, there's this feeling that our patients are too frail, they can't get FLOT, they're too old. Well, we've treated people in the 80s on the study, and in the subgroup analysis, patients greater than 65 tolerated and were able to complete it just as well as people who are under age 65. What's important also, 92% R0 resection, which is excellent and on par with historic carbotaxol RT data. But also I think what's good to know is that we're able to deliver peri-op FLOT durva, and we do not compromise the chances of surgery, right? It's nearly 100% of patients were able to get before surgery FLOT durva, and it did not compromise addition of durva, the likelihood of resection, and the likelihood of being able to add additional adjuvant therapy. In fact, more than half of those patients completed a whole year of therapy. So going back to our patient, and probably the other most common question I get asked, what do you have next? So this is actually the patient I saw in the clinic. This is the guy I showed you his scans, and he had a complete response, YPT0 and 0. So of course he's cured 4 years later, but he's living without his esophagus and stomach, and obviously, it's a big quality of life issue for him. And so the question is, how do we push the envelope? How do we improve? And now the field is really moving forward to non-operative managements. And we're also, the next step in the phase is to combine tumor targeting and tumor-specific antibodies such as trastuzumab, of course, extrapolating from our KEYNOTE-811 data in metastatic disease to peri-op setting. This is a nice study that was already published from a German group for peri-op, pembro-tras FLOT, showing a very high complete response rate. So again, combined blockade with anti-HER2 immune checkpoint blockade may be a good strategy for those patients. We're also doing bringing antibody drug conjugates to perioperative settings. So we're doing a combination of Claudin ADC with anti-PD-1 TIGIT with chemo for Claudin positive, HER2 ADC TDXT for HER2 positive with, again, anti-PD-1 TIGIT and chemo. And for all comers, the next generation of Matterhorn, which is FLOT RILV, which is PD-1 TIGIT bispecific. And again, to see if we can push the peri-op response to immune checkpoint blockade, and also, again, harness the power of tumor-specific antibodies. So in conclusion, we're really are convinced across 4 different phase 3 studies that resectable tumors are really systemic diseases, right? They all will recur if you don't give them systemic therapy, and doing it before surgery is better than after. FLOT is the standard, and now we're building on that. And I think the biggest step forward for the Matterhorn study is that we created a platform of feasibility across the world, across Asia and US, and now even increasingly in Republic of Korea and Japan, Taiwan, and even China. The investigators, I just came back from China, I was there for 2 weeks, and investigators are recognizing that doing surgery first is an outdated approach, and certainly no one's radiating these patients anymore, even with G junction tumors. And the benefit is consistent across PD-L1 and nodal subgroups, and the future is bright for our disease. So this is our team in New York. Thank you for your attention, and I'm happy to take any questions.
Thank you, Yelena. Brilliant as always, and giving us insight into something that we should be integrating into clinical practice. So I am just going to share my slides again. So you asked if we have a surgeon on board, and that's why I said we have a very diverse group of people. Dr. Usman is our resident surgeon here on our panel, and we've also got a nutritionist, Dr. Maitha is here, and of course, 2 other medical oncologists. So Dr. Usman, maybe you can take the first question. And do you think that we should be routinely performing staging laparoscopies for our patients? And if so, who should we be focusing on, or is it just everyone needs it up front before we embark on any type of therapy for these patients?
Thank you, Shaheenah. Good practical question. And thank you, Yelena. Great talk. We enjoyed it as always. I believe in exhaustive staging NOS for all tumors, any thoracic tumor. The thoracic cancers are just bad cancers. Having said that, to me, laparoscopy makes more sense for Siewert 3 and more distal tumors. So if there's more gastric involvement, then I would push for laparoscopy. Certainly, if there's any radiographic concerns, then absolutely we should be looking at things more carefully. But for Siewert 1 and 2, primarily, upper GE junction tumors, and certainly anything above that, I typically do not advocate for laparoscopy.
Okay. So, Yelena, you mentioned very clearly that in Matterhorn, there was no mandate to actually do staging laparoscopies.
Yeah, only a third of the patients did laparoscopies. And I think if we did do more aggressive laparoscopies, I suspect the R0 resection rate would improve, because often, if the laparoscopy was not done, it's the radial margin when you go in and you try to resect it that was the failure. I think, to be fair, I don't really think it's feasible for everybody at every center to get laparoscopies. In fact, for us, like if it's a distal esophagus, like Siewert 1 tumor, and the patient is fine and there's nothing, if you have a high resolution CT scan that kind of reassures you, we don't always do it. But I often find that it is helpful for the surgeons, because these people are always referred from another center. So it's a nice way for the surgeon to just get familiar with what's happening at the primary tumor, and also at the same time get us another fresh sample on endoscopy, and also put in a port. So practically for our center, it's easier to do that.
Yeah, I would just add to that the whole idea of laparoscopy was initiated before we had good PET scans, right? So this is a bit of a historical artifact that's lingering on in management of particularly gastric tumors. So just to add to Yelena's explanation, I would say that I'm usually more careful with poor histology. So for anything that has signet ring cell in it, I am very, very cautious, and that's where we pull the plug on anything.
Yeah, exactly.
But coming to that point, since you didn't mandate PET CTs and you didn't mandate staging laparoscopies, Yelena, could there have been a subgroup of patients enrolled in Matterhorn who actually did have peritoneal disease, but we simply were not aware of it?
Well, no, we were aware of it because hopefully, I mean, look, if you had peritoneal disease and you cleared it, congratulations. But I don't think I think all those disease patients then were deemed, they were still in the intent to treat population. But that's why if you look at EFS versus DFS, right, in Matterhorn, EFS is the intent to treat population, everyone who was randomized. DFS are people who only were if they had successful surgery. And that's why those numbers are slightly different. But absolutely, there were people who, were kind of in oops situations where they were randomized, but then went through everything. And then when the surgeon went in, they saw metastatic disease. I think for the point well taken about diffuse gastric, it's critical. And overall, in general, as our systemic therapies are getting better, of course, we're pushing the envelope. And the people that you may be missing, the PET is not that useful. I mean, I think the PET for peritoneal disease is not that useful. High resolution CT scans are, but even those people you may be missing with cytology positive disease.
Exactly.
And now we're increasingly, I mean, not me, but people in, my group, hopefully will come up with some strategies for IP, intraperitoneal therapies. So there's a stopgap study that's finishing up accrual where, they're just giving Taxol, which is not exciting, but it's something. But, as IP therapies are hopefully going to now come on, I think detecting cytology positive disease as early as possible may be a good strategy. It's not a common thing. It's probably like 15-20% of patients, but it's, and I think I don't think in my lifetime it'll be a phase 3 global study where laparoscopies are mandated. But I think if at a tertiary cancer center, if they could do it, it's a nice way to do it.
So Dr. Go ahead.
Sorry, another subgroup that we struggle with, obviously peritoneal disease is cats out of the bag and, we're just chasing things, but the patients who have nodes outside of the typical surgical field, so retroperitoneal nodes under the pancreas, these are areas where you typically would not resect these nodes. And we would consider them advanced disease patients. They would not have gotten cross or definitive chemo-RT, perhaps in some centers they would. We see those and struggle with those in our tumor boards as to where to draw the line. And then if those nodes disappear after a couple of rounds of chemo or chemo IO, then what do we do with those patients?
So I can tell you what our DMT does. So to be clear, and you have to start the narrative with the patient from day one. You have stage 4 disease. Whatever we do, it's unlikely to cure you, but we do consider surgery in these situations because it does, I think, give them longer progression-free interval, and again, may offer local disease control long-term, right? So because if it's a little lymph node recurrence, as opposed to like a big bulky tumor recurrence, it's different. So the way that we do it is we start with often with flat durva, or if they're HER2 positive, give them HER2 inhibitor with it, etc. But even if the scan is better, and it's often they do respond very quickly, we push the treatment for 6 months. And often we have to stop the dosi, for example, the third drug, and keep pushing. And then when the time comes and they've already had a maximum response and everything is good, we scope them. If the primary tumor is still in place, now sometimes EGD is negative, because if they had such a nice response, the primary is gone. And then you just continue them on maintenance treatment. But if the primary is in place and everything else is gone, we start with a staged resection. We do the laparoscopy, and then usually GU guys, the same people who do seminoma, will do retroperitoneal lymph node dissection, get that out, and then take the primary out.
So you really do an aggressive type surgery in these patients?
In young patients, yeah. I mean, the pancreas lymph nodes are tricky because you don't want to be in a situation where you need a Whipple. Like if it's like one of those really local extensions, we don't do it. But even if it's below the renal bifurcation for RP lymph nodes, and it's been 6 months and we discuss it at DMT and the patient is aware that it's a high-risk disease, occasionally we do operate in a younger patient.
So let's, go ahead.
Cleveland Clinic, both in Ohio and here in Abu Dhabi, we've sort of pushed the systemic therapy timeline to a year.
That's
Um,
reasonable too, yeah.
right? And then if they've not progressed during that time, then we take them to
Can
surgery.
potentially think about it.
That's
We've also had a couple of questions like that. So let's push on to some of the other questions. Dr. Ahmad, maybe you can tell us where the insights are at your center prior to surgery. Do you guys do a psychological assessment and rehabilitation?
Yes.
And post-operatively, do they do an ERAS type of protocol? Because I know, at least in my part of the world here in the UAE, outside academic or outside tertiary care centers, it's not actually typically done.
Yes. So we are not very far from your side. So fortunately, in Oman, we have almost everything is centralized. So in our cancer center, it is almost all the cases are being referred to our hospital and to the Royal Hospital. So we are doing all what have been already discussed. So yes, we are doing psychological assessment, extensive rehab program with the dietitian being involved from the beginning. And fortunately, we are lucky to have incorporated this protocol from the beginning. So all our patients are being extensively staged, reviewed before, and started on Durvaflot. So we are doing, of course, what has been already discussed. The staging laparoscopy is mandatory in our situation because all our patients are being treated at our center. There is no referral to be operated only with us. So the patients are lucky with this regard.
So, Dr. Khouri, maybe you can take this question. Do you routinely test for all the biomarkers in your early stage patients? And the metastatic, it is obviously standard of care, but you're not really using PD-L1 and HER2 and Claudin in early stage. So, do you routinely test for all these biomarkers?
I mean, as you know, Dr. Shaheenah, we sent for a comprehensive panel, which includes all this. But the question is, what are you going to be using? Of course, MSI, deficient MMR is very important because some of these people will benefit from a non-operative approach. PD-1 is important to decide about durvalumab, although, I mean, are you going to follow the NCCN guidelines about it being more than or equal than 1? Or are you going to use it in 0? That's a question to be discussed. HER2 new and Claudin 18.2, I don't think they have any role in early stage. So we do a comprehensive panel, but the most important thing is to know how to use it.
So, Yelena, maybe I can come back to you. In patients who are MMR deficient disease, is there opportunity to de-escalate the chemotherapy and use either dual immunotherapy or just FOLFOX plus Durva, especially if you have that older patient? I have to say, I recently had a patient in his 70s, and I don't know if I have the case here. Yeah, this is the case. The 70-year-old man is married with 2 children, no comorbid. It was a clinical T3N1M0 gastric adenocarcinoma. And you can clearly see he's got MLH1 loss and PMS2 loss. Although it wasn't a Lynch, I had sent it off, it wasn't a Lynch. And the question was, could we potentially de-escalate chemotherapy in this type of patient? He was very worried about taking FLOT, and especially after he'd done his own research about it. Although he was fit, he was still in his late 70s.
And
so
where was the tumor location? How far into so it would be subtotal or total?
Subtotal.
Yeah, so I mean, listen, for MSI tumors, realistically, if it's like really distal gastric and you could get away with subtotal gastrectomy, if you just do, like if he came in with bleeding or something, or if let's say he's 85 years old, you know, I think if you just resected, there's like an 85% chance he's going to be cured without anything. So it's, you know, that's why it's so important to know if they're MSI, because it's theoretically justifiable just to still do surgery. Would I do surgery? No, because like if it was me, you know, or a 70-year-old, because there's still a risk of cancer recurrence even in MSI tumors. So then what you could do is we typically, you have access to Nivo-IPI, right? It's approved. Yeah.
Yes, it's in
So
the NCCN guidlines to actually give it in the neoadjuvant setting.
No, I know, but it's like, I don't know what people do or what yeah. So I just give them, you know, Nivo 3 IPI1 or Nivo 240 with IPI1. maybe 1 or 2 cycles. And if they're not responding, because the problem with MSI gastric is that it's an admixture of MSI and MSS clone often. Or even with, like, if he's like, I just had a patient who's older, was bleeding, like really a lot of bleeding. So, you take Nivo-Ipi takes a while to kick in. So for her, for example, I did Folfox Nivo, and then I started Nivo-Ipi. But I think Folfox IO or Folfox Durva or Flow Durva is totally fine with them.
Okay. Dr. Dia, what would you do with a patient like this? He has
You
not
already,
had surgery. This was
yeah,
this was preoperative. So what would you do?
I would do the same. I mean, as you already mentioned, I would go for a dual immunotherapy like Nivo-Ipi, the same dose as it was mentioned, and after that, patient will be taken to surgery. And after surgery, according to the response, in general, we continue with adjuvant Nivo-Ipi for up to 1 year.
So, Dr. Maroun, do you use FLOT4 or do you use a modified FLOT flow in your practice?
It's usually the flat regimen for 4 cycles, and now we're adding Durva, but I use full flat.
So,
It's what,
Elena, yeah, go ahead.
as long as the patient is in good shape and he's minimal comorbidities, then we use the flat regimen.
So, Elena, do you routinely do DPYD testing for all patients
We
prior to?
do now.
Yeah,
We have
because
to, yeah, it's a
here
new
we
thing.
mandate it. I know Khouri's had a number of patients who've ended up in the ICU with
Me?
no, I'm just kidding. I thought I'd
No, I mean, it's so rare and it's so annoying that we have to do it. For our patients,
Yeah.
but now it's the law because they put it in the Xeloda package insert, capecitabine package insert. So we have to do it.
We do it only with Xeloda. We don't do it with 5-FU. I've never had a patient on 5-FU who end up in the ICU. With Xeloda, yes, but we do it all. I don't do
Our
it with.
institution now mandated it with both. I've never had a DYPD case in my whole entire life. And of course, the other day I had a HER2 positive patient who's perfect for a trial. And his DYPD came back like whatever, it was some variant, and he wasn't, I mean, he's fine, but we couldn't put him on the trial because of it. So it's just so like disappointing.
So I can tell you that I've had 2 patients with DPYD deficiency, and we didn't know they had DPYD deficiency. This was a couple of years back, and they did end up in the ICU. One had received 5-FU and one was capecitabine. So if you have a DPYD deficiency, it's not specific for CAPE. I think it can happen. The toxicities would increase irrespective 5-FU or capecitabine. But it's good to know that everyone tests. I can tell you here in the UAE, we do test routinely. I don't know, Khouri, do you test for your Folfox and your FLOT patients, or are you only testing for CAPE?
I'm only testing for CAPE, but probably the first cycle of flat or Folfox, I give a little bit like 2,000 milligram per instead of 2,400, just as a test. But I don't test DPD for 5-FU.
Okay, Dia, what are you doing in your clinic?
I mean, to be honest, we are not testing, although, as you said, I myself, I had one patient. It was really a severe reaction. After we did it, it turned out to be DPD deficiency. And unfortunately, that patient died. So it was really very bad experience. But unfortunately, I mean, we started doing it at that time, sending the specimen outside. But currently, we don't have it, and because of the insurance limitations, we are not doing it.
Okay, Dr. Usman at Cleveland, I don't think you guys are doing it because I've had a couple of patients from your end where they're not being tested. But maybe it's just a one-off.
Very few. I don't think they're routinely tested.
Okay, all right. So, Dr. Dia, do you routinely give GCSF prophylaxis in patients who are getting FLOT?
Yes, I do. This is my practice. All patients, I give them the GCSF prophylaxis. You know, it's given every 2 weeks just to
Yes,
make sure
exactly.
patients are really recovering on time without any delay.
So, Elena, was it mandated in Matterhorn? I cannot remember if it was mandated to give, but what are your clinical pearls for giving FLOT in clinical practice? I can tell you, I'm like Dr. Dia, that I routinely give GCSF prophylaxis because these patients, they do end up in the emergency with neutropenic sepsis. And we've seen a very different tolerance across different ethnic groups. Our Asian and Middle Eastern
Right.
patients tend to have a higher incidence of febrile neutropenic episodes. So we tend to give GCSF
Yeah,
prophylaxis.
in
What are
Japan
your-
also. Mhm.
Yeah. So what are your thoughts here?
I usually give it, so I can tell you, like, the practice patterns are variable. Not everyone in our group does it. I often give it with the first cycle and just see how the patient does. And if the white count is elevated with subsequent cycles, I don't do it.
Okay. Okay, Dr. Khouri, yourself?
I do give GCSF with flood, definitely.
So, Elena, maybe I can ask you this question. You know, the way Matterhorn was designed, you give perioperative, flood durva, and then postoperative flood durva. But if your patient, it's great the case you presented, this patient had a PCR, did well, you're going to give the same postoperatively, patient's going to do well. But if they have an R1 resection or they have residual disease,
Yeah.
do you think that flawed durva at that point? I know it's a purely hypothetical question. You've got
No,
probably
no,
got
it's
a million
practical. It's very practical. I think they're two very different things, though. R1 resection versus just YPT3
Yeah.
and 3 disease is very different.
Okay.
The YPT3 and 3 disease was actually studied. That question was studied, right? Whether or not switching them to something else like Nivo-Ipi versus continuing FLOT. And Nivo-Ipi was detrimental. So I think if, again, what I mentioned is that I decide based on what the patient looks like. And I look at their weight. I ask them what they ate last night, how much weight, if they're still losing weight, if they're not, doing well, and it's been only 4 or 6 weeks, I push their assessment by another 2 weeks to see. But if they're doing okay and they're feeling okay, I would resume FLOT, maybe with a dose reduction. I very rarely continue the same doses of FLOT adjuvantly. Most of the people need a dose reduction. I drop the leucovorin, I decrease the oxaliplatin by 20%, dosi by 20%, and then they do fine. R1 resection is very different. I'll give you, I'm just doing my clinic prep for Wednesday, my busy clinic. I have 30 patients in one day usually, all gastric and esophagus. I'll tell you one young woman from Romania, actually, bad disease, diffuse, poorly differentiated carcinoma, very fit patient. She's like our age, very fit young woman. I call us young already. So anyway, so she got no response, 11 positive lymph nodes, and an R1 resection. Bad, right? And she had a good surgeon. It's just bad luck, bad disease. I think, diffuse gastric cancer, as was nicely mentioned, has this propensity. So for her, she's claudin positive, PD-L1 positive. So actually in her, I'm going to recommend pivoting to capecitabine with zolbetuximab and anti-PD-1. Because her local doctor was like, oh, let's do radiation, let's do this. Why? She has 11 positive lymph nodes. She has essentially metastatic disease. Radiation is not, the only people I do adjuvant RT in people with, a poor, like R1 resection is if it was just like no lymph nodes, zero positive, it was just a, bad surgery with some person who's not a cancer surgeon. But it's patient, so I would not do adjuvant FLOT. That's crazy. It's too much, right? So I would in her treat her as metastatic disease, give her Zolbi. Guess what? After total gastrectomy, she's tolerating Zolbi very well, right? Because she's not going to get nauseous. So that's why I think it's important to do biomarker testing in early stage disease, because we know they're never early stage.
But then if you give Zolbi for a patient like this, how long would you give it for? Because maybe she doesn't pop up in terms of her.
She's going to be metastatic. I give it I don't know, 6 months, a year, depends on how they tolerate it. So I evoke like the Checkmate 577 data and then, give it for 10 cycles, it's fine.
Now, you mentioned something very interesting. You mentioned the Vestige study in which patients were, re-randomized to get either nivo-ipi versus the chemo if they had high-risk post-op disease. But I think part of the reason why that study was a negative study, like it was a really negative study, patients who got
It was
nivo-ipi
detrimental.
worse, it was detrimental because they didn't actually receive any neoadjuvant immunotherapy. So can we
I don't think
really
so.
can we really extrapolate it to everything that we're doing?
Look, I mean, the world is not perfect. You're not going to have a study just to answer like every nuanced question you have, but this study is pretty definitive.
Yeah.
That, I mean,
No,
the short answer, yes. I would extrapolate it. Yes, you can, and you should.
So, Dr. Usman, maybe we go to you, and then I'm going to ask Dr. Maitha a question as well, because it sort of extends into it. When you get patients who have already finished their FLOT, and they do rather well, because as oncologists, we're awesome. We just get patients really ready for you really well before you take them for surgery. Post-op, you crap them out, and then you bring them to us. What sort of rehab do you do for these patients to optimize them before they reach us for adjuvant chemotherapy?
Well, thank you. No, I am very fortunate to have great oncology colleagues, a lot of them here on this panel. As has been mentioned several times in different contexts, our job is not just to administer our respective therapies, but to make sure that we are treating the patient, not just the disease. And a lot of times our treatments end up being worse than the disease. To give you an example, in today's time at a center like Sloan Kettering, at American Hospital, at Cleveland Clinic, most R1 resections that you're going to see are from bulky necrotic nodes that just cannot be resected. But for primary tumor that's touching the diaphragm or the pleura or those are the part of the liver, most good surgeons, thoracic surgeons or gastric surgeons are going to resect that completely. That's really not an issue. And if someone has those positive necrotic nodes, then it's really not a matter of R1 resection. It's as Dr. Janjigian said, that's essentially stage 4 knocking on the door. So to get to your question, so I think those things have to be looked at in that context. To get to your question, esophagectomy or esophagogastrectomy are morbid operations. They change the lifestyle, they change patients' nutritional status. So it's not as much a matter of what we do or what we have to do after surgery to get to adjuvant therapy. I think we have to start before surgery or even before we start the new adjuvant therapy. So this is where our prehabilitation or nutritional support kicks in. I think all of us have to pay close attention to it, and we do. So it's whatever the patient needs. We've had patients who've had feeding tubes placed before they started their neoadjuvant treatment, or it used to be a little bit easier and cross. They could eat quickly. Now sometimes they take a little bit longer. But the esophagitis is less, so I guess that's a good thing here. Some patients don't need feeding tubes at all. If we sometimes set weight targets and would boost them with admission and TPN for a week or two to get them on track if they're falling off of track. So a weight loss of more than 5 kilos at any point in that first year from the diagnosis onwards is very concerning. And that's where we should pull the brakes, get together, and figure out what to do with that patient and individualize their treatment plan. So I'll just leave it at that.
So, Maitha, we have a number of these patients that come to us after Dr. Usman's done the surgery, where they're really struggling to bring that weight back up, and that can impact the way that we give chemo because they're not as fit. It's difficult to deliver the chemotherapy. So from a nutritional aspect, how do you rehabilitate these patients to get them to the point where we can give them chemotherapy?
So, of course, after the surgery, patient will lose a lot of weight and appetite, or also muscle mass will reduce. and there will be a symptoms of fatigue and tiredness. So usually after the treatment, when the patient is hospitalized, patient will be in strict diet, like there is phases. So there is a clear fluid diet for 2 days, then full liquid diet, then pureed diet, then soft diet, then small regular diet after 1 month or 2 months later on. So usually whenever I receive the patient after the surgery and they already lost a lot of weight and they feel fatigue, symptoms of low appetite or nausea or loose stool will be there. Usually I'll give them personalized diet. So it will be every 2 hours they will eat something that I will focus in high protein diet, which is very good for wound healing and also like adequate calories. So I will hide the calories in whatever it is, whether it's smoothies, soups, I will give them recipes. If I see the patient is not compliant or there is a problem with the weight, it's either it's a stable weight or the increase of weight is low or the energy level is still low, I'll start to give nutritional supplement. And of course, if there is already in feeding tube, it will be very helpful for me. So I'll start to give them nutrition supplement through the tube.
Thank you.
Do you ever recommend continuous glucose monitoring?
Yes, usually I do recommend that because usually patient who is not really eating properly, their sugar level drops suddenly, which is
But
can be
also
dangerous.
even when they do eat, I think, seeing how for the reactive hypoglycemia for a high carb load meals, or even sequencing protein and then followed by simple sugar carbohydrates if they are going to indulge, I think it would be very helpful for the patient.
Yes.
So, Yelena, in the last 3 minutes, I want you to please explain to me what was the wisdom behind NCCN
Don't ask me. I have
recommending.
I don't look at it. I have nothing to do with it.
No, because that's what's
No
happening.
idea.
That's what's
Yeah,
happening in the
I think
community.
they're trying to fix it, but I don't know. I have nothing to do with NCCN. But NCCN is a very, in a way, selected, like it's just a few people are sitting around the table and making up their, and it's often non-experts voting on things. And so, yeah, I don't know. It's very
But you would,
confusing to me
but you would
too.
recommend that we not test for PDL1 in patients.
I test
who are-
PPD-L1 because it's, again, more information is better, and it's complicated to test, not test, because, it's nice to know. And I can tell you most patients are everyone's PDL1 positive. And the other day I had a PDL1 negative patient, and I called the pathologist and they said, oh, sorry, it was like a typo. How hard is it to find one cell positive? So, but I would still test. I think it's good to know. But we treat irrespective. I have not had any issues getting it.
Okay. Dr. Khouri, you
Just,
have the
just
last.
one comment.
Yes, Dr. Dia. Yes.
Shaheenah, sorry to interrupt, because this is causing us problems whenever we apply for approval from the insurance. Unfortunately, they ask us to send them the pathology report, and if they see that that's negative, they reject, and with a statement, this is not in line with the good clinical practice. So I hope they will change it.
Email Jafar Ajani. Not my. Yeah, I agree with you. I think you should email.
I will
Also, I think
email
then
her.
you should call your pathologist and say, like, which antibody did you use? You'll be surprised. Sometimes the other day I called them and they're like, "Oh yeah, it's gastric. Oh yeah, I have to do." They were doing TPS, not TAF.
Yeah.
All right.
Assume
Very,
people,
very
our
last
disease is
question.
narrow, so.
Very last question, so Yelena can go back to her clinic. Yelena, in 2026 on Monday, which is Monday for you, which patient do you think can still benefit from Checkmate 577?
No one. Only those people who are like, I'll see somebody who came in to see me. Some surgeons are not so knowledgeable, so they were diffuse gastric cancer. The EUS was T1B, which in diffuse gastric cancer means nothing.
Nothing, yeah.
So T3N2 disease.
Oh, okay.
So we're giving her Folfox-Nivo or Folfox-Durva or Flow-Durva or something like that. So we're not doing FLOT, but you just you know that you're not mounting a good immune response. But chemo RT, please do not radiate. And if you have a radiation doctor who still, some people, radiation doctors are very strong in a DMT, so you have to just move away from it.
Cool them down and say no radiation. I can see Khouri smiling because I know he's got some strong radiation
Oh my
oncology.
gosh, it's a radiation lobby is very strong. And in fact, because I have a lot of my fellows who go practice in Ohio or other places. So, and then the way around it, if you can't really get around it, open a study. Because you're like, well, I'm going to treat this patient, right? So that there's no question about why you're not doing radiation, but slowly move away from it and just be vocal in your DMT. And I think it comes down to the surgeon, right? Because often the surgeons also, they're the ones that have to operate. So I think if you're supportive of your surgeons, thoracic surgeons as well, then you can move away. But I wouldn't let people get radiated. I haven't radiated a person in the last 6 years, maybe 8 now already. So
Okay. Well, thank you very much. I know that
Again,
everyone has to go back.
sending my hugs and all the best, and hope to see you again in a better time in person. Take care.
Absolutely,
Thanks.
absolutely.
Okay.
Everyone keep safe and Eid Mubarak. Hopefully
Thank
we'll
you.
all celebrate Eid despite the tensions that we're currently facing. So
Yeah.
thank you
Okay.
so much.
Bye.
Take
Thank
care.
you.
Bye. 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 Bye.
Bye, doctor.